Hey, this is Carrie from Wrap Your Head Around Silks. This is the Expecting Aerials podcast, now with the Digitant Network. Thanks so much for joining me and tuning in. If you haven't yet, please check out the Artist Entrepreneur podcast. I co-host it with Noah Dock and Amanda Ritchie. Join us as we navigate our artistic businesses. And just announced, I'll be at NECA, the New England Center for Circus Arts, January the 2nd through the 4th. So it's a silks immersion, 11 hours of silks on their 30 foot plus ceilings. If you want to start the year off with some serious training, let's get your mittens and your coat and let's go to Vermont and train. All right. If you guys are interested, my comprehensive online course for beginner to intermediate silks, anywhere you are in the world, check that out. And then Aerial Rehab is an online course. If you are coming back from pregnancy, injury, or surgery, it is meant to be the bridge between PT and your favorite aerial class. I'm teaching all over the place this fall, and check it out, and let's get started.
Hey, girl.
Hey, okay, so check this out. This is the closet that I've been recording in. But before, it was just me recording in here because it's got the best sound quality in our entire house. Ace has decided that I'm right about that, and he put a whole drum kit in the closet.
Okay, listen, you do the things you got to do, girl.
And so now I'm squished.
Okay.
And then I'm sitting on 2 yoga blocks. And
it's okay.
We have a whole house.
You have good posture. Good posture.
We have an entire house, and this room is giving studio level quality. So that's where we're at. That. You know what I'm saying?
Well, I do not have studio level quality. I have 2 cats that will be walking across this computer multiple times. Speaking of computers, in my old age, my old 47 age, I have figured out that I have like zero concept or understanding of how electronics work. I have a computer, I'm air quoting. I don't have a tablet. My phone messages don't show up on the screen here. I don't know how to connect this stuff where I can just seamlessly do all the seamless download, load, all the stuff people do to make their life easy. I'm like trying to forward text messages like I'm a granny. I think I might take that like 28-day internet course for old people.
This is where we're at, Janae.
Okay. Well, I don't know how to explain the internet to a person. So we go.
But you know what? You know why this makes sense? Because you've been doctoring. You haven't been technologically anything.
Oh, I have no idea where my stuff ends up when I save it. Sometimes I'm like, I know I push save as.
Are you on a PC or a Mac?
I don't know.
Does it have an Apple on the back of it?
It says Samsung. What's that?
You also have kids. You have kids, and they can totally.
I have an adult and a 14-year-old child. I do not have children.
Okay, yes. But you have in this generation, they can totally help you. You know what I'm saying?
Look, my awesome team got me this cute cup. Hang on. I also have one that says, I work where you play, but thought was inappropriate.
Oh
for the
my God, no, but I love that.
I know, it was great. It's actually a wine cup, so, if you're having a little sauce.
And listeners, I finally got the chance to meet 6'7". Oh my! Do you hear that? Do you know what 6'7" is?
Yeah, we're not doing that. Yeah, I'm not doing that.
She just said it all day long.
Yeah,
all day long. Okay, so I finally got to meet Dr. Janae in the flesh.
Yay! It was so fun.
I know, and so did Bean, and Janae's eldest Jaden came and visited with us, and we got to meet her, and she's the best.
Yeah, she's amazing.
Oh my God, yeah. I hope I'm that successful.
She's such a good human. She's just a really good human, so I'm really proud of her.
Is she still living at home right now?
Absolutely not. She has not lived here since she was started at college.
Okay.
She's at State, and she's actually an RA. She was an RA last year.
That's right. I forgot she's living on campus.
Yeah. So this is her last year. She could have graduated last year, but she got a scholarship because she's so awesome, and wanted to utilize all her scholarships. So she's triple minoring instead of going out and to get her big girl job this year. She decided to take some more classes. So she's triple minoring.
Man, if I was in that position, I would just stay in college for as long as humanly possible,
Right.
I mean, not graduate school because that's serious, but like college is like.
Yeah.
So I really wanted to have Dr. Janae back on the podcast to talk. So throughout all of my conversations on this podcast, there comes up many, many times where me and the guests have no idea what something is. Zero idea. And then I put it on my little notes to, in the future, ask Janae. And so this is our mailbag. I don't necessarily have the names of the guests and the listeners that have posed these questions, but I did write the questions down. So number one, I don't really understand preeclampsia.
Okay.
Can you explain that, like preeclampsia for dummies?
I can't wait to do that. So, and as my preface, Carrie did not give me a list of these questions. Guys, so I have no idea what you're going to ask me, but I'll talk about it in my little Janae way. What you need to know about preeclampsia is to start to talk about preeclampsia, let's start to talk about hypertension in pregnancy. So hypertension in pregnancy in layman's terms means my blood pressure is too high. There are three types of my blood pressure is too high, 1, 2, and 3. My blood pressure is too high in pregnancy because I'm always have high blood pressure. Like I have high blood pressure whether I'm pregnant or not. That person is called a chronic hypertensive. We already know you're going to have high blood pressure. Then there's people who get high blood pressure because they're pregnant. There are two categories for those people. One is called a gestational hypertensive, which means I got high blood pressure only because I'm pregnant. And then there's called a preeclamptic, who got high blood pressure only because I'm pregnant and some other crap started happening. Okay, so 3 types of high blood pressure. 1, I'm always have high blood pressure, no matter if I'm pregnant or not. 2, I got high blood pressure because I'm pregnant, but nothing else is wrong with me. 3, I have preeclampsia, which means I got high blood pressure because I'm pregnant and there's some more things wrong with me. So the reason why those 3 situations matter to us is because we've done a million studies, and when it is that it's safe to deliver your baby depends on whether you have high blood pressure because you always have high blood pressure or because you got high blood pressure because you're pregnant. Those 2 things are different in our understanding of how babies do if we leave them in your uterus for a long time. The short version is if you're a pretty controlled person who, hey, I always know you have high blood pressure, we don't have to mess with your medicine too much, yeah, blah, blah, blah. We let you go to 38 to 39 weeks before we start seeing some shenanigans happen with the placenta and blood flow. But if you have gestational hypertension or preeclampsia, you need to be delivered no later than 37 weeks and 0 days gestation. It's not it wasn't that bad. If you start getting high blood pressure because you're pregnant, your body is responding to the hormones that come from the placenta and from the pregnancy. And the only cure for that is delivery and removal of that placenta. So we need to get that out of your body, but we want to measure that according to what is safe for your baby. So if your blood pressure is not too bad, but you got it because you were gestational hypertensive or preeclamptic, we'll let you go to 37 weeks. But if your blood pressure is like a hot, holy mess, I can't get it under control, you look as a mom like you're not doing well for us, then we might need to deliver you before 37 weeks. So the difference, so we clear? That was a lot.
Yeah, I'm trying. I think so.
Picking up what I'm putting down?
I think so. I'm trying.
So high blood pressure because I wasn't pregnant, we'll let you stay pregnant for a while. Okay, I know you have high blood pressure. If you get high blood pressure because your body is allergic to your hormones, you either only have high blood pressure or you have high blood pressure plus some bad shenanigans happening to you. What are those bad shenanigans that make me preeclamptic? The bad shenanigans are, hey, not just my blood vessels are cramping down in my body, but my blood vessels are cramping down in my organs as well. So the things that we check to make sure somebody doesn't have preeclampsia is we check your kidneys with a creatinine level, because if your blood vessels are cramping down, which makes your blood pressure high in your kidneys, sometimes your kidneys don't respond well to that. So you don't filter protein the same way that you're supposed to in your pee. The measurement of a level called creatinine, which is how it is that we measure how well your kidneys are functioning, starts to go up. We're like, I don't like this. You're not just having high blood pressure, you're having high blood pressure affecting your organs, which means things could be worse. That's preeclampsia. Another organ that can be affected is your liver. If you cramp the blood vessels down in your liver and you're not getting appropriate blood flow, you can have your liver get irritated about that. And so we have things in our body called liver enzymes. It's AST and ALT. You don't care about that, but we check that to say, hey, are those levels going up? Not just up a little bit, because your liver enzyme can go up if you drink too much bourbon for a second, or your liver enzyme can go up if you get hepatitis. Your liver enzymes can go up for a lot of different reasons. But if your liver enzymes are going up because your blood pressure is high and you're pregnant, 2 times normal, not just like a little bump, but 2 times normal, we're saying, looks like she has preeclampsia instead of just high blood pressure when I'm pregnant. We don't like that. Our brain is another organ. There's different things that can happen inside of our brain that can make us have symptoms of preeclampsia. This one is a funny one because almost everybody gets a headache in their life. Almost everybody gets little floaters in front of their eyes is what people call it. If I stand up too fast right now and I'm not pregnant, like every once in a while I'll see a little stars in front of my eyes if I stood up too fast or something like that. We're talking about sustained, irretractable headaches that are not amenable to Tylenol or any other medications that we can give you for your headaches, things like that. If you have that, then we say, is our brain having a little bit of a squeeze in there, a little bit of high blood pressure in my brain? That could be a neuro symptom of high blood pressure. Edema, which is swelling in your legs, is no longer in the criteria of preeclampsia. People come in, their moms will say, we used to say that. Please, 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 everyone know that that is not a criteria for preeclampsia anymore because almost everybody who's pregnant gets swollen. If you eat a lot of salt, which our American, traditional American diet has a horrific amount of sodium in it, we can't say that somebody is preeclamptic just because they have swollen legs or swollen feet. So that is not in the criteria anymore. What also is not in the criteria anymore, which I'm kind of mad about because I'm old, is we used to look at the baby as an organ, right? An organ of pregnancy. So if my baby wasn't growing well, was really, really small, I'd say, oh my gosh, maybe I have high blood pressure in the umbilical cord and I'm not getting enough blood flow to my baby for it to grow the way that it needs to grow. So I'm going to look at that as an end organ. That is no longer in the criteria of preeclampsia. So those are the 3 things. Let me say it again, just so we know, and then I'm going to go on about how we evaluate it. But 1, you have high blood pressure because you're pregnant.
Oh, there is a cat going across you weren't lying about that.
Yeah. I'm sorry. You have high blood pressure and you're not pregnant. That's called chronic hypertension. 2, you have high blood pressure only, and that is because you're pregnant. That's called gestational hypertension. 3 is you have high blood pressure only because you're pregnant and something might be wrong with your brain, your liver, your kidneys, or in the old days, your baby. So those are the 3.
I think I'm going to have to re-listen to my own podcast to really understand that. But it was very
the high blood pressure.
It is very clear the way that you put it out. I'm just going to have to go back and go through the study guide of my podcast to really understand that.
It's okay.
Okay, so
I will say though, if you get high blood pressure in pregnancy, it's not like everything was fine and then you showed up with a very clear diagnosis of preeclampsia. That's the really frustrating thing for people is that sometimes they'll be like, hey, when I was at home, my blood pressure was really high, so they told me to come in. You come into the hospital and your blood pressure is normal. And so we don't diagnose you with hypertension, and people get really nervous about that and really scared. But a couple things are really important. 1, stop using your grandmother's old cuff from behind the spatulas, wherever she kept it for the past 25 years. And then because you were nervous and you just drank 60 cups of coffee, you took your blood pressure because you were nervous, didn't know how to use the cuff, blah, 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 blah. And then you come and tell me your blood pressure is 190 over something, and I tell you it's 120 and you're mad at me. Stop doing that. You don't take your blood pressure on non-calibrated cuffs. If you think you have a blood pressure that's elevated and you want it evaluated, we can't wait for that. But I need you to bring your blood pressure cuff to the hospital with you so that we can check it against ours, which is calibrated, and show you how to use your cuff appropriately. Because believe me, it is not our intention ever to send somebody home with high blood pressure, but we definitely want to make sure that you are assessing it appropriately and that you know how to do that. You do not take your blood pressure when you're in a fluff. You do not take your blood pressure after you just got in a screaming match with your partner. You do not take your blood pressure after somebody almost slammed into you in the car. We do that serially. If we need to check pressure, we check them 2 to 3 times a day at the exact same time every day, so that we can get a really good assessment about what's happening with you. And the diagnosis of hypertension has to happen over time. If you have 1 elevated blood pressure, it needs to be validated for at least 4 hours. So you need separate blood pressures apart from each other. 1 blood pressure doesn't do it. So if I look back in your chart and you broke your ankle and you had a high blood pressure in the emergency department, doesn't mean that you're a chronic hypertensive.
I had one guest say to me, she went in to the hospital. She went into her doctor at like 37 weeks. I don't know if she had she must have had a symptom. And she and they were like, you have preeclampsia. We are inducing.
Okay.
Does this happen a lot where there is?
Yes.
Yes. Okay. Can you explain?
You are not allowed, if you have preeclampsia, if you are beyond 37 weeks, because remember what we said, if you have high blood pressure all the time, we're like, you got high blood pressure all the time. We'll let you go to 38, 39 weeks if you're controlled. But if you have high blood pressure for any reason, only because you're pregnant, the recommendation is that you do not one day go beyond 37 weeks.
Okay.
So if you come in with symptoms and you're 38 and a half weeks and you have high blood pressure plus anything, or just high blood pressure on its own where I've diagnosed you with those, you are indicated to be delivered that day.
Okay. So women out there, we just don't know this, right? So then there's like a mental like, what? Where
Yes.
really we should know this going in, that if you are like, even if you don't know you're hypertensive before that, if it says at 38 weeks that you are, then that A plus B equals C.
A plus B, yeah, but scoot it back to 37 weeks.
Okay.
If you are hypertensive sustained, like not just one time I had it, if you one time had it in the office and they send you to the hospital and your blood pressures are normal in the hospital while you're resting and not having just drank your mocha latte and snatched your kids and kicked them out into daycare like I had to do, and like my pressure was probably always 170 over something. If we lay you on your side and over 4 hours your blood pressures are normal, you will go home. Then okay, you didn't meet the criteria.
Okay.
But if they send you for assessment for preeclampsia or hypertension at all after 37 weeks, you definitely have the risk of being kept and being induced. I don't say that to scare a person, but yes, that is definitely the indication.
So people know this going in, because I had never heard of that. So had I been in that position, I would have been like, what?
Right.
Wait.
Which is why we tell people, hey, pack a bag around 36 weeks and just throw it in your trunk. You know, you could be at the grocery store and break your water. You just don't know. So just having that in your bag, so that at least you're minimally prepared for something to happen after 36 weeks, just takes the stress off of you. So,
Dr. Janae, let's just say you're not seeing the doctor. You're not seeing your doctor at all during your pregnancy, and this happens. What are the potential complications if this goes undiagnosed?
If you have no prenatal care?
Yeah.
You're saying? Fetal death is the worst one, right? So if you have undiagnosed preeclampsia and
So the baby, not you.
the baby and maybe you.
Oh, okay.
Right? So it was horrible. Who was was she a track star? Black woman track star who was like 38 years old, who they found in her home, who's pregnant. Dead. Was that last year?
No, I never heard that story.
Seizure. Yeah, I think she was an Olympian. Don't quote me. I'm sure I could Google it on my phone real quick. But yeah, she had died from an eclamptic seizure in her home with no one there. So the short of it is, for if you never had your blood pressure checked during pregnancy and you walk around with, essentially it's like two ways you can think about blood pressure. If you're going to draw fluid through a straw, let's make it easy, right? So I have a cup of water and I'm just sucking up through a straw. If I put twice as much water into the cup, to be able to get the water through the straw, I have to suck twice as fast to get the same amount out, right? You understand what I'm saying?
Yes. I'm taking notes too.
So then the pressure in my straw, if I have to suck it up twice as fast because there's so much water in my cup, is going to be higher in my straw. That's what we have when people have fluid overload, like they have too much extra fluid in their system. Makes the pressure in the straw really high. That's high blood pressure. Your tube, the straw would be like your blood vessels. It's extra. The second thing that would happen is, what would happen if all my straws were twice as small, like a coffee stirrer instead of like a regular straw? If I'm trying to suck a normal amount of fluid through a coffee straw instead of a regular straw, the pressure in there is going to be a lot tighter, right? Because the volume, the space in my straw is so much smaller. Those are the two things that can happen in preeclampsia or hypertension. So if my pressure is very, very high and I cannot deliver blood flow appropriately to the organs in my body, over time, if nobody sees that, I can end up with kidney failure. If I don't get blood flow to my kidneys because I'm preeclamptic, I can end up with kidney failure, which means I need to be on dialysis or have a a kidney transplant. That means I can't eliminate waste appropriately from my body, which will back up into my body, which can cause me trouble. The other thing that can happen in my brain, if I'm not delivering oxygen appropriately to my brain because I have high blood pressure, you can have a seizure. It's called an eclamptic seizure. If you have an eclamptic seizure and no one is with you when you have an eclamptic seizure, to help tilt your head to the side, or you vomit during that seizure, or have brain damage because of that seizure, you can lose your life from that. You could have a stroke because you have high blood pressure that's uncontrolled. So absolutely, one of the things we have to do with preeclampsia is put people on magnesium sulfate to try to protect their brain from having seizures. And it's a really, really scary thing. And unfortunately, there's a pretty high percentage of people who have mild range pressures, not even severe pressures, but mild range pressures, who can still have a seizure. So we take it really, really, really seriously when someone comes in with high blood pressure in pregnancy, or if they have any laboratory abnormalities that show that their kidneys are not functioning right, their liver is not functioning right, their brain is not functioning right. We take that really, really seriously because, yes, you can lose your life. If your preeclampsia or hypertension is not controlled and the blood flow to your baby is not appropriate, you could end up with a stillborn for untreated preeclampsia. So yeah, you could lose your mom or your baby in worst case scenario.
I think what happens in a lot of conversations I'm having with these women is that I think it's safe to say that it's never been explained or communicated to me that it's the seriousness of that. So I think a lot of women, because that's the case with them too, they've never, or they didn't understand how serious that could be, that the biggest thing is, I'm getting induced. I never wanted to get induced. Right. Where really, if they understood what's on the other side of not being induced for that, it's way more serious. And to just to be more worried about the outcome of that than your birth plan changing.
Yeah, and I think too, in defense of doctors, I don't sit down with a normotensive 19-year-old BMI 27 girl at 20 weeks and talk with her about
correct
all preeclampsia.
Yeah.
That's not. I don't have, number one, time for that, and number two, it's not pertinent to her. Just like I wouldn't talk to her about if she had an amputation, because she doesn't have an amputation.
Yes,
you know what I mean?
Yes.
It's not pertinent right that second. And usually preeclampsia or hypertension doesn't matter until it matters. And so we can do a better job, explaining the consequences of and why we need to do X, Y, and Z. And I want to hold space for people who do have a plan or a best case scenario in their brain about how they want their birth to go. And please know that any provider, that's our goal too. I don't ever want to have someone come in and have a bad experience, but I also want to give them a healthy baby. And so we have to balance that. And if we go in with openness in our hearts from both clinical side and patient side, where we can have a patient-centered conversation about what are the things that I can still do for you to make this experience as good as it can be, in light of the fact that we have a situation here, I think that can sometimes lessen that. But if someone for 9 months thinks that it's going to go a certain kind of way and then it doesn't, there's grief in that, and so we hold space for that. But also there's timeliness that I know you're upset, but I'm sorry that you are, but here we are, so we don't have 4 days to go home and think about that. Or if you want to take your 4 days to go think about that, you have to sign a refusal of treatment form, or something like that, because we have to send you home. So, or we have to say that you're, doing something against medical advice, but it's not even close. It's not even close in our studies to say that let a preeclamptic go past 37 weeks or just keep working. There's not even anywhere in any literature anywhere that would agree to that. So that can feel really constricting and really you're not giving me any options. And honestly, there aren't any. The options that you have if you're past 37 weeks and you're diagnosed with that is delivery, either by induction or cesarean section. And the one good news is that people that are preeclamptic, a lot of times, even though they haven't had a baby before, their labor process is a lot quicker than somebody who isn't. So even if we had you on the magnesium to treat your not to treat it, to save your brain, and the other medications we give you, even if we you were not in the best way, we still would like to give you the opportunity for a vaginal delivery if it's safe, and so One of the things that can help bring your blood pressure down is an epidural. I know a lot of people don't want an epidural if they have a certain birth plan, but that can actually lower your blood pressure, which is another way to keep you out of trouble, and lower your risk for seizure, which is why it's recommended. Also, sometimes babies don't look good for a preeclamptic. So if I have an epidural in you and I had to do an essentially emergency C-section, you don't have to get put to sleep. So we do it to protect the opportunity for you to be awake during surgery in case we had to do that, instead of you getting put to sleep with a general anesthesia where you can't have a partner with you in the room. And that's really, really scary. It can cause PTSD for patients and things like that. So in anticipation of having an awake delivery, if we had to proceed with cesarean section, I do recommend epidurals for patients with preeclampsia.
So I've been doing this podcast for 5 years now. And the fact that like I'm talking about this every week and I still don't know things. It's just there's so much that could and does happen.
Yes.
That how would you explain every possibility to anybody?
Correct. You can't.
Right. Okay. So this has come up many times where, like, for example, Bean she was angled in a funny way and she didn't drop down in my pelvis. And didn't drop down into, like she just, my cervix was like not moving, blah, blah, blah. And the question comes up with so many of my guests, like, are there any tools that their doctors or midwives could have used in that situation to find that out before the baby comes out? Like, can we use an ultrasound? Is that even like effective in any way? Like because it feels like a lot of women feel like the doctors didn't use any tools to maybe find that out beforehand. That, you know what I'm saying?
Yes, I do. So I want to, as gently as possible from my space, give you an example of what that sounded like clinically.
Okay.
When you said, my cervix didn't really, blah, 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 didn't drop down to my pelvis, and kind of in there a little bit funny. That would be the same as me saying to you, I went to take this class where there's like, I don't know, ropes all over the place, and we like do some spins up there. And like you get up on this high thing and then you like twirl around, you put the thing around your ankle and your wrist, and then like you're supposed to stretch out an X and like swing across the stage. So I don't know what the big deal is and why they act like they have to have a certain kind of strings and they have to have a certain kind of, and like just get up there and do it. Okay, that I love you is what that sounded like to me as a provider. So a couple of things, which I don't know how to say it. And I tell people all the time when I walk in, hey man, people have been having babies, mammals have been having offspring for 1 billion years, right? Mm. So nobody had all these tools back 1 billion years ago. And our C-section rates, by the way, were a lot lower back then for a whole bunch of different reasons. So giving someone the opportunity to have a vaginal delivery is standard of care. Sometimes babies are turned OP, which means the back of the head is facing their pubic bone. That hurts. It's called back labor. There's nothing to do about that. Your baby just did that. When my cervix doesn't open up and my baby didn't come down, those are two completely different things. The whole process of labor and descent of the head into your pelvis happens in a stepwise fashion, typically, where your baby kind of corkscrews in there a little bit. It turns as it comes down. So if somebody's cervix is closed and their baby is really high, let's pretend that I'm using an upside down pop bottle, right? The cervix is the nose of the pop bottle. If the baby is up in the pop bottle and not down in the nose, it's going to be facing however it's going to be facing. As the nose of the pop bottle dilates and opens up to be the same size as the rest of the pop bottle, the baby's going to come down in your pelvis and twist a little bit and turn its head either to the right or to the left, and then descend, and then extend, and then flex, and do all of these different things that are a process that time tells how that's going to work. I can't make your baby do anything. And sometimes people whose babies are facing a traditionally difficult way to come out push 2 times and their baby comes out. And sometimes people who the baby's positioned in the exact perfect way, push for 3 hours and their baby does not come out. But yeah, I could evaluate you with an ultrasound and see that your baby is in the posterior position, but that doesn't mean I'm going to do anything different about it. Your baby's either going to come down in your pelvis or it isn't. Pelvimetry, which is where I assess like how far apart are the spines in your pubic bone, how far apart are these different things, those dilate or stretch out through the labor process. So I would never commit a person to, you're never going to have a vaginal delivery without giving them the opportunity to do that, because we have elastin in our system that loosens up all the cartilage in our body so that our pelvis can expand to have a baby come out. So there's some AI tools actually that are being evaluated to say, hey, if I just stuck an ultrasound over top of someone's pubic bone and just evaluated which way the baby's facing, maybe to give mom or somebody else some more knowledge about it, that's fine. But the outcome doesn't change whether or not they can have a vaginal delivery or not. So no, besides a baby being breech, and us having the opportunity to turn it back to head facing down, your labor is going to be what your labor is going to be. And some people, their baby's facing a way that's hard to push out and they literally push 2 times and their baby flies out. And then other people have a 6-pound baby facing perfect, which is normally looking down towards the floor, and they don't accomplish that. So I would respectfully say everyone deserves the opportunity to have a vaginal delivery if they want to try that. Some people's pelvis is tighter than others and they're going to have to push longer than somebody else, but it wasn't a not success. Because someone pushed 30 minutes and somebody pushed 2 hours. It's not a reflection on someone not having enough clinical knowledge. Second is, how do people adjust and move when we ask you to adjust and move? There are a million things we can do with our peanut balls, which are those big yoga balls. How it is we can position you in your bed. Hey, roll on this side, roll on that side. That'll tip and flip the baby in different kinds of ways that might make it easier to deliver. And some people, being honest, are opposed to that. I don't like the way it feels on this side. Well, then, okay, then that's on you. I'm trying to get your baby to twist and turn to get down, to come down here. Some people, whenever they are really uncomfortable, if they're unmedicated, have a difficult time pushing through that pain. That has nothing to do with the way your baby's facing. That's excruciating, so if they don't want to push against that pressure, it might take them a little bit longer than somebody else. Sometimes an epidural might make it harder for someone to recognize when it is or how it is that they're supposed to push. So we work a little bit harder on that. But respectfully, no, nobody's not doing something for you at 35 weeks because we didn't do a special ultrasound to find out which way your baby's facing, because I don't care how your baby's facing. You're going to go through your labor process, and I'm not going to turn your baby a certain kind of way you haven't dilated enough for your baby to come down in the pop bottle. So I don't know how your baby's going to turn. Some babies, when they go to come down, they turn their face straight forward. It's a face presentation. That needs a C-section. Some babies put their hand on the top of their head. And so when I go to check your cervix, I'm holding on to a hand. I'm like, hey, that's a hand presentation. There's nothing you can do about those situations. So respectfully, ropes on my ankles and knees and making an X in the air. No, team here. No, your doctor's not doing something for you for not using an ultrasound early in your labor process.
Okay. So this conversation happens a lot because even with me, I was in labor and I had a epidural, so I wasn't tortured like it could have been. But sure. After the C-section, doctor was like, yeah, the baby was facing a certain way. I don't know if it would have happened vaginally. So, blah, blah, sure. blah. So in my mind, because I was like, I could have not done these 30 hours. You know what I'm saying? But what you're saying...
That's not what they meant. What they meant was, this is an explanation as to why your particular baby it stayed unrotated.
I see.
But you 10 out of 10 times deserve the opportunity, because 8 out of 10 times the babies in that position rotate. The other thing is that cephalopelvic disproportion, which is called CPD, we recognize after the fact, which means cephalo, head, pelvic, your bones, the head and the bones of the pelvis didn't open up right. I don't know that they're not going to open up until you put pressure on them from ahead. So if if we give you the opportunity and your pelvic bones never open up and the baby stays super, 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 super high, then your cervix won't open up. Well, we don't know that until we give you the opportunity to try, because your pubic bone has a break in the middle of it, right? Like it's supposed to stretch. And so it either does or it doesn't. So we don't know that until we give you the chance to.
I see. Okay, that makes sense.
Because your pubic bone can open. Like there's right in the middle of it is your pubic symphysis, and it's cartilage, which means it stretches. That's why it hurts so bad right in your pubic bone when you're going through labor. And when we push on it to measure your belly, that's why it hurts like that, because it's not bone, it's cartilage. So it can stretch.
Oh, see, this is why we have to ask these questions instead of me just asking these women. And we're like, why? Why couldn't they have made it better for us? Okay.
I've had people I have a patient who's 4'11", and she only has 10-pound babies. She's 4'11". So every time I see her, she's like, well, the doctor told me that I probably aren't going to make it. That's not true. You deserve it. I checked her cervix myself. I'm like, your pelvis feels adequate. Let's give it a try. She had a 10-pound baby, didn't even tear. And all the babies that she had after that, her pelvis was appropriate. You know what I mean? Like, I think everyone deserves the opportunity. I've also had people who I checked them and was like, girl, this is like a paper towel roll in here. I don't know. I don't know what's going to happen. I don't know. We can try it. And they surprised the heck out of me. They pushed for 3 hours. Their pubic bone opened up. It took them 3 hours to do it. Squeeze. That little baby had a little cone head looking like, I don't know what. It'll fix itself in 3 days. Don't worry, guys. But she had a vaginal delivery. And I told her, this is going to be a rough go for you. But she did it. And so everybody, after doing this for 25 years, I think deserves the opportunity, unless under certain really messed up circumstances, deserves the opportunity if they want to try.
Yeah. Okay.
Because you don't know until you try. Now, for people who don't want to try, I give them grace for that too. If you want a primary section, you're welcome to it. But there's nobody who's going to be able to tell you that you 100% were not able to do that unless there were very certain criteria.
Got it.
We don't just guess like, your baby seems a little bit big, unless you're past 5,000 grams on an ultrasound assessment if you don't have diabetes, or past 4,500 grams on an ultrasound assessment if you do have diabetes. Those two criteria, because your shoulder dystocia risk is so high, is when we would start talking about primary section. But that's darn near 11 pounds. So that's a whole different conversation.
Oh my God. See? I'm so glad I asked. Okay. Mm-hmm. Would you rather let somebody naturally tear than snip, snip?
Okay. So what I want to do and what I do are irrelevant. We do what's clinically been studied. We don't routinely do episiotomies on patients just because. When I was in training, I had some docs who that was their routine. Like, oh, she's going to crown, snip. We do a snip and then it comes out. That is not the case, and it's not indicated for us to be doing episiotomies on everyone anymore. There are certain reasons why you would do an episiotomy. They would include a potential shoulder dystocia, which means the head came out, but the shoulders didn't come out. You can consider maternal exhaustion. Like, they can do it, but the mom says she just can't push anymore. And there's just that little band that's there. So you may help give her some more room because there's maternal exhaustion. If you're using a vacuum, or forceps, you want to do an episiotomy to make more room for yourself then. If you have extreme fetal distress, like I need to get this baby out right now, and she could do it, but she just needs a little bit more room. And so you do that for fetal safety. But just for convenience for myself, we don't just do that. We let people push through that. As far as like which one's easier to repair, it's easier for me to repair something that's straight instead of something that's not straight. But there's a lot of things that are easier to do than others. And we don't do that for my personal comfort. We do it, for maternal indication or for fetal indication. So no, it's not standard of care at all for people to just standardly do episiotomies. And you should be consented, right? Like I shouldn't. And I've had patients come and tell me this, and it really hurts my feelings. Like they're like, I don't know what was going on, something. And then all of a sudden I heard a big snip. My husband about passed out because there's blood and there's scissors, and then the baby came out. That is inappropriate from us as a clinical standpoint. Like we should say, hey mom, looks like XYZ, baby's heart rate, you're really tired, whatever it is. Would you mind if we gave you a little extra room? And this is how this could happen. It's our responsibility to consent a patient for what I consider that to be a procedure. So we need to have verbal consent for us to do. And then you would have it explained to you. But I mean, I can't speak for everybody because I do know there are providers out there who they're just tired of waiting, and so they'll just do an appease to get it done or get it done with. But that's not with our body of evidence that we have currently. Shouldn't be standard.
Flipping to before, we're talking about labor a lot.
Sure.
Okay, so this one happened. This is another guest that happened.
Okay.
She was breastfeeding. She had a breast reduction previous to being pregnant.
Okay.
And she had trouble breastfeeding.
Okay.
Is this something that you've heard about, experienced, etc.?
Oh my God. 1000%.
Okay, please explain.
Yeah. Well, they should have talked with her about that before her reduction. I'm certain they did.
I'm not sure.
Okay, well, there's two types of reductions, right? So, and we have to think about the breast. Whenever we get pregnant, people experience extreme growth in their breast tissue, right? I'm a cup right now, itty bitty titty girl, and I love it. I don't want to have a bra on right now. Thank you very much. But when I'm pregnant, I'm out of a double D nursing bra. It's horrific. It hurts so bad. So the growth and the amount of distortion to the breast tissue and the hypertrophy, which means increasing the increase of the tissue, is really, really significant. Also, we're increasing our blood volume by 50% when we're pregnant. So there's a lot of engorgement and blood flow that goes to the breast tissue that changes the way that our nipples are situated and changes the way that, because if you have to have a duct to produce milk, you have to have blood to bring nutrients to that space to be able to make milk. So if you have a breast tissue that is non-pregnant, it's completely different when it is, I don't say completely different, but much more vascular and different when you are pregnant. It's like they're two different organs, right? So if I do a breast reduction, and depending on the way that the breast is sitting for a woman, when I reconstruct it, I want to put the nipple back in this place that it looks anatomically appropriate for the woman.
Mm-hmm.
So for the patient. So when I'm doing that, depending on how your breasts are situated, if you stand up and your nipples are facing the floor, that's different than someone who just has rounded breasts that are really large where the nipples are facing forwards. Does that make sense?
Mm-hmm.
Mine are flappy, so mine face the floor. Somebody else, like my sister, looks like they are facing forward, but they're huge. So when you go to replace the nipple, you could disrupt the entire blood flow, cut the nipple off completely, do the reduction, and sew the nipple back on in what is considered an anatomically appropriate position. Well, in that case, you have disrupted all the blood flow and the ducts to the nipple, where that person would never be able to breastfeed again. But the conversation is, hey, if you don't care about breastfeeding anymore, I'm going to take your nipple off and then put it back in the place so that it anatomically looks appropriate. Versus, hey, I might want to breastfeed, so I'm going to need you to, good luck, go in there and make a stalk underneath my areola, where all those ducts are coming through, where all those blood vessels are coming. I want you to make a stalk under there so it's held on to that, and then go around the other tissue and get rid of that other tissue, and then re-sew all that back together and leave that stalk right there so that my nipple can pass milk through it. And then hope that the blood flow and the suture and the scarring and all the things will give me enough connection to allow me to breastfeed. It is standard conversation for someone to have to say, we're going to do the very best that we can, but you may not be able to have a successful attempt at breastfeeding like you would before we disrupted it, which is why most people don't get a reduction until they're done with their potential or childbearing, so that we don't do that to them. But that is, I mean, you're taking out, most people, if they're getting a reduction, are losing, up to 2 to 3 pounds from each side. Just think about how it is that I'm expected to reconnect all of those. You cannot reconnect ducts. So you're asking it to try to come together in a way that will support breastfeeding. It's extremely common for people to struggle with that.
Okay. And is there just as many problems if there's an implant in there?
No, absolutely not, because an implant is
behind all of that.
Most implants now are underneath the muscle.
Okay, yeah.
And they're not in the actual duct tissue. So back in the old school time, we would just open the skin, stick the balloon in there, and shut the skin. We'd put the balloon over top of the breast tissue, the ducts and whatnot. Now we put it all the way under your pec muscle so that it lifts it up, and I don't do anything to I'm not really messing up the breast tissue. Like I'm putting it underneath all the breast tissue so that I'm not messing up.
On a side note, like my pecs are so tight from what I do. It would my implant would be like underneath my collarbone by the time, you know what I'm saying? I don't even understand how doctors do that.
Sometimes they have to put an expander in, where we put this little balloon in there and then put some more fluid in it every couple of weeks until it gets to the space where I could do that for you and this, that, and the other. But that patient, if you're getting implants, is struggling with a different issue, right? They don't have as much tissue there. So that's different than somebody who has too much tissue that I'm taking tissue away. It's a completely different scenario. Yes. So.
Oh my God, it's so fascinating. Okay.
So yes, I would definitely say there are some patients who have a reduction, zero problem breastfeeding. They're like, yes, best thing I ever did. I breastfed fine. And some that are really disappointed. So I do not recommend anyone doing that until they're done. If it will be emotionally trying for them, if they were not able to breastfeed, then I would say don't do that until you're done with your childbearing.
Okay, Dr. Janae, I'm not going to take any more of your time with these random ass questions.
You're fine. This ain't bothering me. You can ask me for 2 more hours and cut out what you don't want and make it an hour show or whatever you're doing. And by the way, I told Carrie yesterday that I was going to try to quit cussing as much. I think I'm doing okay.
But why? But why would you want to quit cussing? It's lovely.
I don't want to offend anybody who might, you might want to forward this to them. And you're like, if they were my mom, no way would you forward this to Susie Davis, because if I was cussing, then she'd be like, oh my gosh, so I can't even listen to this. So I was like, you know what, let's make this a little more user friendly. And these are some questions that really, I want to be impactful. If you're talking about an ex-husband or something, I'll be mother blanketed all the way up. But since we're not, I could talk about breasts and the vagina in a clinical way, with a little humor doused in there every once in a while. Okay,
I think my audience just like loves you. So, I do. I'm completely obsessed with you. So I'll take you in all forms. Okay. When it comes to older moms.
Yes. And what do we mean? What are you saying when you say older? 47. So I'm going to say 62 is an older mom.
Okay, no, then that's not the question. When the woman is in let's just say the woman was my age. I am 48.
Okay.
I already feel the effects of my decline, my hormonal decline.
Sure.
We're the same age, you and I, ish.
Yes.
And I do not want more children. But if I did.
Okay.
What would your advice be to somebody who is 45, 46, 47, 48, all those, in that age group? What would you say?
Sure. I don't want to say that it would be advice. It would be questions that I would pose to them so that they can make a decision that's in their best interest and in the interest of, where they're at in their life and for their family. For somebody who is 45, 46, 47, 48, if you want to use your own eggs, you need to recognize that your eggs are 45, 46, 47, 48. I think I've talked about it in a different podcast. We were born with all the eggs that we'll ever have, right? And so when we start having our cycles, early teens until about 50 to 55 years old, our body is selecting one of those eggs that they considered that was the best. And it's the youngest. And so has less likelihood for chromosomal abnormality, right? So the further we go in our life cycle, the less optimal egg pool we have available to us the older we get. So also, as we just talked about with hypertension, as we go through our life cycle, our risk for having other conditions not associated with pregnancy increase. So our risk for diabetes is much higher, which means your risk to contract diabetes when you're pregnant is much higher when you're 45 than when you're 25. Hypertensive disorders in pregnancy are extremely common for the age group of people who are 45 to 48. Miscarriage rates because of the chromosomal abnormalities that can happen with the eggs is extremely high. Cesarean section rates are higher. Protracted labors are higher. Things like that. So if someone came to me and said, hey, me and my partner decided, we're empty nesters or whatever it is, and we want to do this again. I'm not here to ever tell a person to do or not to do. That's not my position. My position would be, here's the risk factors associated with that. You would be considered a high-risk pregnancy. Your preterm labor risk is higher, all these different things that are higher. If you want to do that, I can't wait to partner with you. Recognizing these are the things that we are going to be on the extreme lookout for. We're going to treat you a little bit differently than we treat a 25-year-old, just so that we don't miss something for you. Here are the risks for aneuploidy, a chromosomal mismatch or abnormality. And if that patient decides that's right for them, then that's right for them. And so I'm here for that. I've had patients who came in unintentionally pregnant at 48, thought they were going through the change, missed a period, I'm gaining a little weight, think it's perimenopause, nope, you're pregnant. If they decide whether they want to terminate or continue that pregnancy. Had some who terminated, some who continued and gave baby for adoption, some who kept. So that's not for me to decide, but you are definitely in a subset of higher risk pregnancy for sure.
Okay. What if a couple froze embryos a long time ago?
Mm-hmm.
And
that's the age of the embryos.
Okay. Is there an age where you would say you should not implant the embryo, because you're at a huge risk to yourself?
So I would defer that to my smarter repro-endo colleagues, but I would say it depends on, I would say it's not safe to implant embryos in an unhealthy mom who's 38. Some people who have cardiomyopathy after their pregnancy, or they were preeclamptic to the point where they have extreme kidney disorder now and disease now, or someone who, had a cesarean section last time and it looked like an S show in there, and it looked like silly glue was in there. And if we go in again, we're going to cut your bladder open and you're going to end up with an ostomy where you have a poop bag on the outside. There's reasons outside of, what's going on with it's more maternal, those reasons. Like, do you have risk factors associated with that? As far as the clinical reasons why that a repro endo doc might tell a person that, I'd have to defer to them. But there's reasons why I would tell anybody not to do it for maternal safety. But if you froze embryos or eggs when you were 25, that's how old the eggs were. They're 25-year-old eggs, even if you put them in a 45-year-old.
Yes. Okay. If you said an older mom, you were like 60. So like
I said that because I'm 47 and I just want to not say anybody close to my age is old. So I do not have any patients pregnant at 60.
This is so fantasy world. But if you had a 60-year-old patient come in and say, I have embryos from when, I was 30, I want to be pregnant again.
Uh-huh.
And she's generally healthy. Mm-hmm. Has this ever happened?
It's never happened to me because I wouldn't be dealing with that. That would be a specialist.
Okay.
And her hormonal status is not, she doesn't have estrogen and progesterone to the level of a premenopausal person. She's not cycling anymore. So that's not a person that hypothetical isn't really, you'd have to do a whole bunch of stuff to her to have a hormonal environment appropriate for pregnancy at a 60-year-old.
Okay. So that's the question. So if you're in decline, even if you're not gone through menopause yet, the hormones are a very important part of being pregnant, just getting pregnant. Yes.
Both, correct.
Yes. Okay. Oh my God. I learned so much from you. My listeners, if you would honor me with a 5-star rating and review, I would appreciate it forever. It is the hardest thing about being a podcaster is to get your podcast out to the people who want to listen. So the best way to do that is to have a good star rating and just ride that algorithm. So I really appreciate if you guys would just open the Apple app and leave me a review. It makes such a difference. I appreciate you. I also have Greener Grass with Digitent Podcasts with my friend Kelly McVeigh. If you want to hear my voice twice a week, it's there for you. It's light, it's heartfelt, and we bring on some really amazing guests. All right, my friends, over and out. This is Carrie from Wrap Your Head Around Silks. This is The Expecting Aerialist.